Hello everybody, I am Dr. Sadhana Gupta and today we are going to discuss a very relevant topic in today's clinical gynecology, that is Adolescent Polycystic Ovarian Syndrome. And we must be aware of the diagnostic approach as well as the methodology for management. I owe a big gratitude that we have stayed together for a long journey in FOGSI, and we know that the PCOS is the commonest endocrinopathy affecting around 15% of the reproductive age population, and it is a very increasingly issue in the reproductive and sexual health of the adolescent age group as well. We do not know exact prevalence of adolescent PCOS in the general population, but it is estimated around to be 1 to 5%, and India being the youngest populous country, we have a big adolescent population who have the PCOS. So, I will today discuss few emerging concepts what we have learned in last 5 to 6 years about the pathophysiology of the PCOS, and till now we know that it is a insulin resistance which leads to hyperandrogenemia and which leads to the anovulation and also the decreased sex hormone binding globulins that cause the peripheral androgen production. So, that is the hyperandrogenemia. The anovulation remains the hallmark of the PCOS, and it is the current understanding what we know. I will say that in the last few years we have known that it is a fetal origin of adult disease, and it is a PCOS manifestation can be genetic as well as the in utero environment that makes a girl or the woman susceptible to the polycystic ovarian syndrome. So, in adolescent what we have the presentation that is considered the classical presentation is the patient is overweight or a girl is overweight, she is having the manifestation of insulin resistance, she has the hyperandrogenesis clinical like acne and the hair growth, but more commonly in our day-to-day clinical practice we have the mixed type of presentation, and we will see that we have the different phenotype in the PCOS. So, patient might be having regular menstruation but having the sign of hyperandrogenesis, or she is having the oligoanovulation but no sign for the hyperandrogenesis. And we in our clinical setting we must be very careful that who are the girls which need the regular follow up for the confirmatory diagnosis of the polycystic ovarian syndrome. So, important thing as a clinician is that what are the criteria for diagnosis of PCOS in adult population does not fit for the adolescent population, and this is a very important concern, because if we do not diagnose adolescent PCOS then we lose the opportunity for lifestyle and the pharmacological intervention, but if we overdiagnose or incorrect diagnose, that cause a lot of mental health issue and the stress to the patient as well as the family. So, adolescent need a handling with the care, and why? Because the physiology of adolescent actually overlap with the presentation of the polycystic ovarian syndrome. So, a normal weight gain is normal in adolescent, a little bit insulin resistance is also physiological in adolescents, likewise presentation of acne can be the physiological phenomena, but we have to think that we have to like follow these girls, that how we can suspect that this girl can have the PCOS. So, PCOS what we have, it is a polygenic disorder like a multifactorial disorder, it has a genetic disorder and it can present as a various form, but the adolescent, the stress, hyperprolactinism, the stress of education, stress of competition in our Indian population, and the thyroid and prolactin disorders are also very common, and we have to always exclude the other causes of oligoanovulation as well as the hyperandrogenism. So, my one takeaway is that because the girl when they start menarche, they have a immature hypothalamic pituitary axis, and that is why a little bit oligoanovulation delayed cycles can be physiological up to 2 years. So, it is important that we know that what are the criteria for the adolescent PCOS diagnosis, and somehow our professional bodies are not on the same page. So the societies which are working for the pediatric or adolescent have a little bit different outlook. So this is one of the main area of the research as well as the clinical studies, that how we diagnose the polycystic ovarian syndrome in adolescent, and why we are so worried about it, because the implication of PCOS, if we don't treat it, are very high. The girl can have chronic inovulation, then infertility, then the cardiometabolic disorder and the metabolic disorders, hypertension and risk factor for the cardiovascular disease. So while our country is having a tsunami of non-communicable disease, we can play a very, very important role if we rightly diagnose adolescent PCOS and we do all positive lifestyle intervention. So what the complexity of adolescent PCOS, that again I emphasize that the risk of overdiagnosis as well as the incorrect or the misdiagnosis, everything is very, very important. So these are few criteria that what we do criteria for the adult population, that is the Rotterdam or the ASHRAE criteria, and we should have the three things, that is the hyperendogenism, oligoanovulation and the polycystic ovarian morphology. So this is the for adolescent, all the three things should be there, and the Sultan and Paris criteria, which shows that at least 4 out of 5 criteria should be fulfilled when we define that this girl can be having the polycystic ovarian syndrome. So what are these 4 out of 5 criteria? All oligomenorrhea 2 years after menarche, sign of clinical hyperandrogenism, increased plasma testosterone, that is called the biochemical hyperandrogenism, insulin resistance, hyperinsulinemia and the polycystic ovarian morphology. So what is say that the at least 4 out of 5 criteria should be available. What are the normal? What I said earlier, that the immature hypothalamic pituitary axis cause the delayed cycles, irregular cycles for the in the adolescent age group. So when we define, if the oligoanovulation persists after 2 years or right from the very beginning, the cycle is more than 90 days or very, very infrequent cycle, then we should start considering that this patient, this girl should be followed up for the polycystic ovarian disease, polycystic ovarian syndrome disease. So this is very important, and normal has a wide spectrum for the menstruation. So it is more than 2 years and the infrequent cycle. However, when there is a less than 20 days or more than 90 days cycle, they are considered abnormal even the first year of the post-menarche year. So what are the criteria for oligoanovulation? That the regular cycles 2 or the more years after menarche, or the menstrual interval more than 90 days in right from the beginning. And the third thing which we are having a lot of population, that the delayed puberty, the PCOS presenting as a delayed puberty. So lack of onset of menstruation by 15 years or more than 2 to 3 years after thelarche, and you find that it is the uterus is intact, genital tract is intact, but the patient girl can have the PCOS. Insulin resistance, a little bit of insulin resistance is physiological in adolescent, but when you see that there is a family history of diabetes, metabolic disorder in parents and family, or they are having overweight, they are having high BMI, then they should be considered for the follow-up for the PCOS. So adolescent, it is not recommended that we do fasting insulin glucose ratio or like a good test for the all metabolic disorder, but in case when the girl is high overweight or there is family history of metabolic disorder, it can be considered. Clinical hyperandrogenism is fair enough evidence for the hyperandrogenism. So inflammatory comedone right from the very beginning. So this is important. Normal acne can be there, but if there is severe inflammatory acne, then it should be considered as a clinical sign of hyperandrogenism. And the hair growth. So for this you have to look at the girl, that what is the temporal hair growth, what is upper lip, then the breast, then the pelvic arm. So we have to look at the girl, that what is the hair growth. So that is the Faring-Hellman score what we can have, and sometime we resume to the biochemical hyperandrogenism confirmation. So clinical criteria, what message I want to give, that the clinical criteria is a fair enough evidence for hyperandrogenism. When it is not there but the girl is having oligoanovulation, you can do for the biochemical testing, that is testosterone index, total testosterone and the free testosterone. But important thing is that it should be always done with the good reference laboratory, that is very important, and it should be the standardized test. However, when there is a 1 or 2 occasional value of the total testosterone, that is not that very important. So, and another message, when a patient girl is having the severe inflammatory acne, then before starting any topical therapy, the girl should be investigated for the polycystic ovarian syndrome, because the treatment can alter the values. So a thorough medical history, physical examination and appropriate lab assessment is essential to exclude other causes of the hydrogen excess, that is very important, and insulin resistant and hyperinsulinemia should not be utilized as diagnostic criteria. Thyroid and prolactin disorder are very common disorder which can manifest as oligoanovulation, and in all girls suspected of PCOS, we must do the testing for the thyroid and the prolactin, that is very strong recommendation. And other common cause is the non-classical adrenal hyperplasia. So in consideration, in backdrop of the clinical scenario, you can consider, you have to have those. So this is what I want to emphasize, that the polycystic ovarian disease is a syndrome, is a diagnosis of exclusion. Now a very controversial point, that is ultrasound manifestation, ultrasound, polycystic ovarian morphology on ultrasound, because every second or third girl is coming to us with the report of that I have PCOS, I have PCOS. So initial, when we didn't have that good ultrasound machine with that good resolution, the criteria was 10 to 12 follicle peripherally and with the necklace pattern. Now we have a very good machine, and the criteria we see that there is a 10 to 12 follicle in a normal girls, in a normal reproductive woman, and now the criteria is the more than 20 follicles on the ultrasound and more than 12 cc of the ovarian volume. So this very important message I wish to give, that not the criteria have changed and we must take that due consideration. And in adolescent girl it is very important, because most often we do the transabdominal ultrasound, and ultrasound should not be considered at least 8 years after menarche. Again I emphasize that the ultrasound is not considered until 8 years of menarche, because it does not give any recommendation. Anti-Mullerian hormone level is not recommended for PCOS diagnosis, and you have to look for the oligoanovulation clinical and then biochemical hyperandrogenism. So this is important, and there are many good papers about it, and I suggest that you all read it. What is the, if we want to do the day 2 FSH-LH, yes, sometime it is needed, but even the all society says that is the like a strict diagnostic criteria. How we can manage these PCOS in adolescent, that is again a very important question, because the girl is just immature, she is coming with her family. So right from very beginning we should determine what I said, that it is not a one time diagnosis, that a girl comes to you with delayed cycle and you label at a PCOS. The girl who can have the probable PCOS, they should be in the follow up for your consultation, and they should be counseled for the follow up for the few years, 2 or 3 years, that what is happening to it, how we demonstrate androgen excess and how to exclude the other causes. So the basic of the medicine is the knowing your patient. So good family history, personal history, physical appearance, waist to hip ratio, and a good menstrual character and the sign of hyperandrogenism, as well as secondary sexual character, signs of insulin resistance, which is acanthosis nigricans, and the dark velvety skin. Always exclude, I am emphasizing, always exclude other endocrinopathy like thyroid and the prolactin disorder are very common with us. Patient can sometimes taking drug, so that also causes the sometimes the oligoanovulation. So when the girl comes to like around 16-18 year, sometime the pregnancy test for the exclusion of pregnancy is very important, and always look for the adrenal tumor and the ovarian tumor in the ultrasound also. So lab investigation, so free, and what I have already discussed, that the testosterone level with the good reference laboratory, and once PCOS is confirmed, it is important that we have to intervene with the lifestyle modification, and in the family history of metabolic disorder or the high BMI, we can go for the oral glucose tolerance test as well as the lipid profile. So criteria for metabolic syndrome in adolescent is the fasting blood glucose more than 100 milligram, high density lipoprotein, triglyceride more than 110 milligram per deciliter, and waist circumference 95% for the age population, and hypertension always to be taken very seriously. So individualized approach is key, and what we have, the first and the foremost and the continued thing is the lifestyle modification. So these are the important thing, and sometime we have to use the pharmacological agent, and we will just discuss. One of the very important message from the pediatric point of view and our cross dialogue with the pediatrician, that once we said that the PCOS appear in adolescence, but now the study says that PCOS manifest, like first is the genetic predisposition, so family history, then in utero environment, and the third is the weight gain, like the epigenetics. So if the girl is having weight gain in pre-pubertal period, that is around 7-8 years, 7-8-9 years, that is the time that we have to counsel the parents about the good diet, because if we have good modification of diet and the plays and everything, because today children are hooked on mobile right from the very early age, and that is causing a lot of issue along with the habits for the junk food right from the early age. So this is very important, that it is an emerging concept that we can catch them even before adolescent. So the second important thing is diet and exercise. So nutrition is the thing today, every professional body, FOGSI, FIGO says that think nutrition first, and this is the mainstay of the therapeutical strategy, and 5 to 10% when the girl lose the weight, then it reduces the manifestation of the PCOS. So the new emerging concept is the dogma theory, that is the dysbiosis of gut microbiota, and it has been proposed that it can cause PCOS. So what we eat, we become. So microbiological hypothesis is a novel paradigm shift, and it says that when we have the altered microbiome due to the high glucose diet, it allows the lipopolysaccharide from the gram-negative bacteria into systemic circulation that cause chronic inflammation and the pro-inflammatory cytokine, and that cause the polycystic ovarian syndrome. So PCOS, like diabetes and metabolic syndrome, is considered as a disease of the chronic stress. So this is very important, and we should not only focus on the quantity of diet but also the quality of diet, but I will say the more important is the quality of diet. So 30 to 60 minute exercise, the diet which is low in fat, low in sugar, high fiber and good in essential fatty acid and protein and antioxidant food is the way for the polycystic ovarian syndrome girls, and we have to give good time for the counseling. The second, when the girl are but trouble and their family also, that the combine their irregular cycles. So if there is a regular cycle, sometime we have to switch on to the combined oral contraceptive, and actually they correct the endocrinopathy of PCOS temporarily. How they correct? They regulate menstrual cycle with dependability, block the activity of plasma androgen activity mainly from the testosterone by inhibiting ovarian function. They increase SHBG, so they lower DHEA sulfate and it reduces the menstrual bleeding and also correct the anemia. How to choose COC for it? So if the girl is having acne or hyperandrogenism, then the cyprotenone acetone combination are a good choice, and when the girl is having overweight, then the drospirenone combination are the good choice. So with the who are having the anti-mineralocorticoid activity, how long we can give? So it is usually for the 3 months, and then we see that lifestyle modification is to be continued, and we see that what is the change, resumption in the cyclicity of the menstrual cycle. But yes, after 3 to 6 months we have to stop in between, because we actually don't know that before age of 18 or what are the long term implication of COC on the reproductive health as well as the bone mineral density. Progestin, it does not correct endocrinopathy, but For the sometime regulation of cycle we use progestin, but I just want to say that it is not correcting the endocrinopathy, and it is a good, like after 3 months of the COC patient is not having the good menstrual cycle, sometime we have to give the this thing, we have to now after COC, lifestyle modification, progestin withdrawal, bleeding, there comes a role of insulin sensitizer. So we have metformin, a long experience as an insulin sensitizer, but I just wish to have one clear message that metformin is not for every girl who is coming with the diagnostic triad of the polycystic ovarian syndrome, but it can be considered in select cases when the cycle and the manifestation are not regulated with lifestyle modification and sometime pharmacological intervention. The second is the select group of the girl who are having overweight and the family history, then the metformin can add to it. But metformin, whenever we give it as a like a GIT issues, loss of appetite, and we must have a watch on the liver and the renal function. So this is important. So insulin sensitizer we can use. Inositol has come in a big way, which act as a second messenger as a insulin resistant by decreasing P13 kinase, and it is a nutritional supplement. So myocarinitol and the D-chiroinositol has been proven in a good number of studies that inositol corrects hyperandrogenism, it helps in reduction of body weight, as well as it reduces the manifestation of the PCOS with the resumption of menstrual cycle. So inositol given for 3 to 6 months along with the lifestyle modification is a non-hormonal treatment, and it acts as a second messenger. So the world is looking for the nutritional therapy of many disease, and the inositol has come in a big way. We have good number of studies, and we have to they have an important role into the management of adolescent PCOS. Sometimes for virilization and hirsutism we have to give the anti-androgen as well. The 5-spironolactone is something, and the fluteramide, but these are the drugs which usually not prescribed by gynecologists, and we have to take the opinion of the endocrinologist when we prescribe these drugs, because every drug has the issue of the toxicity and the adverse effect. The combination therapy like lifestyle modification is going to be with all over life, the pharmacological intervention and the inositol. So these are the things which we have as a armamentarium to treat with the adolescent PCOS. Supportive treatment, mental health issues is very common, because these girls are puzzled by like a delayed cycles which their other peer groups are not having, sometimes relationship issue, the pressure of education and the competition. So be always careful that as a doctor your counseling is compassionate, positive, you are not giving undue stress for it, and you have to look that there are any signs of anxiety or the depression. We have many new drugs and the therapies also for the PCOS, like the Oristal, Infolic and the homeopathy, acupuncture, acupressure, but nothing has proven very useful. We have a lot of research gap also in PCOS, and I think we advise that everyone can do some studies for the many research gap, that what are the normal values of AMH in the adolescent age group, how the presentation, the ethnic variation, what is in our country. So coming to the key messages, that the recent literature underscore the use of standard diagnostic criteria for PCOS developed for adolescent. All adolescent with persistent oligoinnovulation after 2 years and should be managed, should be looked for the PCOS, and the early recognition gives opportunity for timely intervention, and we should have the correct methodology in diagnosis as well as in the management. So the appropriate therapeutical option for adolescent with PCOS should be recommended based on what are the clinical manifestation, and always it should be the positive treatment, supportive treatment, and they must understand what it means. Like they always have to have a right time fertility management issue, right time consultation, and always have a positive lifestyle so they don't develop the metabolic disorder in later life. So thank you very much for active listening, and we look forward for our continued association for the women health and for our fellow obstetrician and gynecologists. Thank you very much.